All right, we're going to start the panelist section of our program. All right, so I'm going to introduce the panelists briefly. As we move through some of the questions, I'll let them tell a little bit more about themselves and some of the work that they do. In no particular order. I guess I could go in order. I'm a very organized person. So we have with us, and you can just kind of give them a wave as I call out your name, Dr. Tony Dickensheets. He's an Army vet, has a doctorate in theology, a volunteer with Soldiers Angels, he's a Dallas VA rep, also with NAMI, Crisis Intervention Training, Community Outreach, and also works with Aero Outreach Advisory Board missions in Juarez. We also have Shirley Weddle. Shirley is a graduate of Paris Junior College, Texas A&M Commerce. She's a community liaison and mental brain health and suicide prevention awareness advocate. After she and her husband, Brad, lost their only child, Matthew, age 22, to suicide in 2014, she began the search for the why of suicide and now collaborates with multiple organizations and individuals to promote brain mental health, prevent suicide, and support those who have lost someone to suicide. Shirley is a charter president and co-founder of the cause-based suicide prevention and brain health Rotary E-Club. I got it all right, Shirley. Okay. We also have Tiffany Cooper. Tiffany is a licensed professional counselor who's been working in the mental health field since 2009. She's currently an intake counselor at Glen Oaks Hospital of Greenville. She has experience working in outpatient mental health centers such as Lakes Regional, the early childhood programs, and Mindful Health of Rockwall. She is very passionate about crisis intervention, and I do know that about you, Tiffany. So, Dr. Tammy Vakahasi is currently our provost and vice president of academic affairs at Texas A&M University Commerce. Dr. Vakahasi earned a Doctor of Philosophy in Counseling Psychology from Texas A&M University and a Master's of Science in Counseling and a Bachelor of Science in Psychology from Arizona State University. We also have with us James Williams, from Lakes Regional Community Center. James currently serves as the Director of Behavioral Health Services for Lakes Regional Community Center. He's been there from 1996 to the present. Also previously worked at Terrell State Hospital and is a licensed professional counselor and a licensed marriage and family counselor. I did not know that about you, James, that you were an LMFT as well. So, and an interesting thing about James is he graduated from East Texas State University from the counseling program in 1976, back when it was East Texas State University. So welcome, alumni. I think some of our staff here our panelists are alumni. Okay, so I'm going to go ahead and start off with some of the questions that we have for our panelists, and you can just sort of pass the mic back and forth as we kind of go through some of them. The first question is more of a general question around how can mental health professionals and community leaders work together to address mental health challenges in rural areas? And Tony, if you want to start, that's fine.
I think the most important thing that we could do today is to help destigmatize mental illness. Until we get that accomplished, we'll never achieve our goals. I myself suffer from a severe mental illness. I've dealt with bipolar for 37 years. And the stigma is definitely better today than it was, or less today than it was 10 years ago, but make no mistake, it's out there. I know that from personal experiences. I've lost things, I've lost people I cared about. And so anything we can do to end stigma, I think that should be our #1 priority, because everything we want to do follows from that.
to follow along with what Tony is saying, we want to promote that mental health is brain health, is physical health. It's affected by multiple factors about what we eat, our exercise, our sleep habits, all those different things affect the chemistry in our body, which affects what goes on in our brains. In regards to the community, what we're doing right now is the first step, is for us to get together and to have honest conversation about what's going on in our communities, what our needs are. And there are lots of great resources out here, but we just don't know about them. So if we start talking about that and looking what the needs are, looking at our at-risk groups, how do we reach out to them? There are some people that can use technology and some people don't feel comfortable with technology. We have to be honest about that and determine how do we reach out to those groups and really look at our resources. For example, our Suicide Prevention and Brain Health Rotary E-Club has connections with North Texas Behavioral Health, with Cohen MetroCare for veterans. We have children's programs. We work with the Halliburton Foundation for young people with NAMI and all sorts of different groups. And our goal is to bring those resources together and make them available to everyone. But again, it's all of us working together and looking at what we can do. We have to start somewhere.
Yeah, I certainly agree with what both of them have said. A lot of the issues I think that we're encountering is accessibility and awareness. So us coming together like this so that we can collaborate and also provide information about what we're doing so that we can better help our communities. I think that that's a major area that we need to improve on. So I think that this is going to accomplish that. Also, what is it, Tony? Is that correct? Okay. What Tony said about destigmatization, that's a major topic that we need to concentrate on, which with the COVID pandemic, of course, there was a lot more, there was some transformation that occurred. I'm noticing it at Glen Oaks. A lot more people come in and they feel more comfortable. They feel like they can actually reach out. And I have so many people who come to me and they're like, I have never, ever, ever even considered actually going to someone for help. So there's a major increase in that. So it's good things that we're seeing.
And it really starts today. As we talk about how we can make an impact in the larger community, I think today is about first talking amongst ourselves. Because if we can't do that, then we aren't in the place where we can really serve our community to the extent that they deserve and that we want to. And I know firsthand the challenges of speaking across disciplines. How do we do that either from the university to the community, the town-to-gown relationship? And we had a president who talked about that valuable connection. And I'm hoping today, in fact, I believe today, that we'll continue to talk about those relationships that we have between the community and the university. But maybe more importantly, or just as important, is the relationships and the communication that will help it happen at each of these tables. Because we each come knowing what we do and our piece of improving rural mental health, but I don't know exactly what other people do from the legal system or from the medical system or even from the judge that I was just talking to and what his day looks like and how he is trying to make a difference and impact our community. So talking with each other, the research says we work with people that we're in close proximity to. We work with each other when we know each other, we understand each other, and that we have a common language. So I think it's very exciting that as we look out, we also are coming together today to look inward and how we can be stronger together.
Well, good morning. I'm a participatory type of person. I went to ET, and so you have to participate in this. So how many people are going to participate in what I'm getting ready to ask? Let me see. How many? Okay. All right. So how many are graduates of university? How many of you belong to your alumni association? How many of you belong to Rotary, Lions, some civic organization? How many of you belong to a professional organization? How many of you volunteer on a regular basis? That's how we do this rural health. That's how we work together, is by participation. And so that's what I would encourage everyone to do. being here is participating, and I think that's what it's all about. When you look at how do we get professionals, law enforcement, politicians, how many are elected here? How many elected officials? Very good.
And you can go ahead and hang on to the mic,
Oh,
James. I'm going to
sure.
ask the next question.
All right.
Yeah, so one of the other questions as Dr. Patras and I were going through this was, what may be some of the potential policy changes or funding priorities that could improve mental health outcomes in rural populations? So talk a little bit more about that. What are some of those opportunities?
Well, sadly, so much of it is around funding, around dollars, around money. Texas doesn't fare well when you look at how much funds are spent in terms of mental health, emotional health, those type of things, for people who are wealthy or for people who are indigent. I work in more the severe and persistent mental illness world as well as in crisis world. And if you have schizophrenia, if you started off wealthy, you won't be wealthy very long because you'll be over in the indigency system because there's not good funding for it. There's not private insurance that treats it very well. So it's about funding. I think we're improving. I think I would recognize two people from our agency here. Dee Dee Thurman's probably my right-hand person. Stand up, Dee Dee. And Ashley Lewis, both graduates of ET as well. And they're big in writing SAMHSA grants. And so we've gotten more funding in relation to SAMHSA than what we have in relation to the state services. Now, I'm not knocking state services, don't get me wrong. They're a big, they provide a tremendous amount of our budget in relation to it. But when you start expanding beyond that in terms of the overall community mental health, it's going to take more dollars. It's going to take more people volunteering. It's going to take more participation. I think the participation at a local level is probably the key. How many of y'all in your community know that known person that's maybe homeless or sitting on the corner, but your community accepts, and if you transported them to the community next door to you, they'd be in trouble. But in your community, you protect them in your ways. How many of y'all have known characters that you know of? How many of you have talked to that known character? That's good. That's what Taylor was saying earlier. It's really about listening. And first you have to engage in terms of that talk and that participation. And I think that's where a lot of the funding comes from, because then legislatures hear that, elected officials hear that, and it really starts at that level of getting more dollars and more emphasis on mental health.
Yeah, and I'll just add, when we talk about the funding, is how can we pull our resources and not maybe duplicate services, but leverage what we each have or can bring to the table. And I'm hoping that's some of the discussions today, as well as you talked about grants. And where do we have the resources and the expertise to come together? Because in today's grant world, it is really competitive, right? Everybody's looking for money. And so I'm hoping that we can meet with each other, bring different disciplines together so that we can write together the grant that's going to really stick out, because we're a community that really is dedicated to transforming rural mental health. With the policies, we know that policies can be impactful, but they don't happen overnight, right? It's going to take a while. And so wondering what could happen today, what are the seeds that we could sow that 10 years from now, when we come together, and I hope we come together way before 10 years, right? The goal is to have a continued focus on this. But just imagine what seeds we could sow today that 10 years from now we can be celebrating the differences and the challenges we've addressed through policy and also funding.
So, yeah, I completely agree with the things that these two have said. Of course, specific areas that I notice things with regard to funding. I just was talking to Adam about like prescription costs. People are struggling to just afford the prescriptions that they're needing to manage their symptoms, and unfortunately there's this ripple effect where if they can't afford to keep themselves stable, then they end up back in acute care. And so there's a cost associated with that. So if we could create more programs for like prescription costs, reducing those, or grants that focus specifically on that kind of need. Also, another area is transportation. Transportation is a big problem in our rural communities. So many people cannot even, they cannot access their providers because of transportation. So some kind of, or more programs that assist with transportation, I think are areas that we could target.
From a legislative standpoint, I was just in Austin last week talking to legislators with the Military Officers Association of America. There are a number of bills before our legislators right now in regards to mental health. A few of those have to do with licensure. One of the things they're looking at is that veterans that come out of the service may be qualified as behavioral health professionals, but it takes a while for them to get reciprocity or be able to have their license in Texas. There are other folks that are licensed in healthcare in other states that may not have reciprocity, may not have a compact in place. So if we can work on getting those individuals licensed in Texas, then they'll be more available, and we'll have culturally competent folks to be able to talk to our members of our communities. Something else that goes on, there's lots of bills right now, especially related to 988 funding. So you can be involved. Your legislators want to hear from you. At least they told me they did. So when I went there, they were very kind, and there are lots and lots of bills before them right now. March 10th was the last day to file bills, but now there's opportunities for you to make comments, and you don't have to go to Austin to do that. You can actually go online, you can write in and let them know how you feel about different bills. And if you'd like to know more about that, we'd be glad to share that. But you have a chance to make a difference right now. Now we have the suicide prevention hotline information on student IDs, as well as other things that are in place. And those all came about through efforts of citizens who are concerned and talk to their legislators to make things happen.
Well, I'll just say, if we treated people in this country who have cancer, heart disease, or some physical ailment the way we treat mentally ill, there'd be a national uprising. That's just reality. It's not just a Northeast Texas problem. It's not just a Texas problem. It's a United States problem. Actually, it's a world problem, but that's beyond our scope. There's nowhere for people to go. Timberlawn in Dallas was a huge psychiatric facility, shut down. Baylor, Scott and White, Irving had a psychiatric unit, shut down. You know why? There's no money in it. They make a lot more doing surgeries. And so I'm not as sanguine about this as some of my fellow panelists. I still think it's a disastrous healthcare system for mentally ill in this country. I probably am biased about that. I will acknowledge that up front, but that doesn't mean it's not so. The simple fact is, and when I do crisis intervention training with police officers, I always remind them of this, and they know it. We warehouse our mentally ill people in jails and prisons. That's reality. And that is an abomination and a stain on our country. So that's my opinion on that.
Just as a note too, you may not realize it, but we have over 1.5 million veterans in Texas, and only 30% of those actually are signed up at the VA for services. So a lot of them go without services, and even those that are signed up have difficulty with the transportation, as you mentioned. Like even from Paris to Bonham, there's difficulty in transportation. I know people I've known judges who had actually put people in their car and taken them somewhere for their appointments. So, and a lot of police departments end up housing folks because they have an appointment the next morning. So there's a lot of things going on like that that we can look at.
While you have the mic, as far as, and you were talking about this a little bit before, Tony, about the destigmatization of mental health. So I'd kind of like to hear from our panel about what are some ways that we can work on better destigmatizing the idea of mental health, that idea of acceptability that someone wants to seek help out.
One of the main things, as I mentioned, is that mental health is brain health, which is physical health. Just like diabetes or heart condition, it's something that you can manage. People can have a heart attack, they have a brain attack for suicide, but you can try to manage that. And I think we need to talk about it in areas that we don't normally talk about it in. We need to talk about it in our churches. You know, in the Bible, there are people in the Bible that had mental health challenges. Why don't we talk about it? Just like we do all our aches and pains. If our muscles ache, we talk about Ted's pain cream or something like that, you know, to make us feel better. So we talk about all those things. So we talk about it in our schools. Our son Matthew was very involved in sports and school. Nobody ever talked about mental health or suicide prevention when he was growing up, or in the colleges, or in our churches, in our communities. Another thing is we need to go where the people are. So maybe we have tables set up at the county fair, Lamar County Fair. We go to concerts. We go to the pancake breakfast. We go to the places where people don't always seek information, but if we're there, we can then provide it, because you never know when you're going to come across that person that needs you. And if we do that and we just normalize it, oh, well, yeah, my brain health, I was feeling a little down, and oh, did you know that if you have a thyroid condition, hypothyroidism, depression is a symptom of that. Maybe you need to take some medication for your thyroid instead of antidepressants. So if you really start talking about it and open the conversation, it can make a huge difference, and that's something we can do in the schools and everywhere.
So I think she mentioned the schools, and that always, for some reason, things always for me circle back around to the schools, and I think that that's somewhat to do with the fact that, I mean, all of us are adults in here, and as we've gotten older, we have developed more wisdom and insight and learned more about mental health and how so many of us are suffering and struggling, and sometimes it seems like even very healthy minds can begin to struggle and suffer in certain seasons of their life. And so, but as young people, they don't really have all those experiences to inherit that kind of wisdom. And so schools, I think that's really such a huge area that we can benefit from if we can reach kids. I always think too, like if we could create programs in classrooms, just like kids go to science class or math class, if they could go to psychoeducation class or something like that, where they learn coping skills or they learn how to address grief issues and things like that. So I don't know, those are just kind of like grand ideas that I have in my head about classrooms, actual classrooms, not just a therapist in the school, because that's wonderful and great. But if we had, in fact, like a classroom that kids attended regularly as part of their regular curriculum.
Yeah, that's wonderful, and I couldn't agree more. I'm going to go to the other end of the life cycle then, and that's our older adults. First, let me say I'm up here as the Provost and Vice President for Academic Affairs at A&M Commerce, but I'm going to take that hat off because, as you heard, I have a degree in counseling psychology, and for over 2 decades I've been a licensed psychologist. I'm a geropsychologist, which means I see people who are 65 years and older, and spend a great deal of time not only teaching and researching about older adults and mental health, but also seeing my own patient load and helping older adults to deal with mental health issues, and also what that happens to you as you get older, and that interaction of all of those kind of variables. So let me say, stigmatization is a very big topic. And what I want to do is just take a second and talk about the need to target different populations. And in my own work, what we did is we targeted men. Men have a very different approach to mental health and how they think about it and how they approach it. Older men have additional needs and ways to talk about it. Think about older men today and the messages they received when they were growing up. Big boys don't cry. Is it James Bond? Stirred, shaken, not stirred or something? The Marlboro Man? All these kind of messages that our men get throughout their lifetime. And as an older man, pull yourself up by your bootstraps. What happens when depression sits in or anxiety and your health starts to fail and you have to be supported or others have to be helpful to you? I'll never forget one of my patients years and years ago. He had been a top commander in the Vietnam War, and he was in a nursing home, and I was seeing him because they were worried about his depression and his giving up on life. And he looked at me and he said, you know, at one point, I commanded over 20,000 people in the war, and I can't command one person to help me go to the bathroom. That was a poignant moment for me, and that I still remember that, and I'm wanting to share that with you. Kind of drives home, I think, the need to look at each and every individual, but then its segments on how do we join their worldview, so when we do reach out and talk about stigmatization, that we're talking to them and their lived experience so that we can join them to help them move forward to a way that they need to be in getting the help.
You know, I always thought women thought different than men about those things. I didn't know we were thinking different than women. My grandparents worked in state hospitals in Oregon, Texas, and Kansas. And my mother and brother retired from what then was Abilene State Hospital. And then I worked at Terrell State Hospital, lived on the grounds for 17 years, raised my family there. And so I started in 1977 at an outreach clinic in Mount Pleasant. And when you look at what stigma is and what, you know, how the community looks at one another, back in those days, there was no priority population. We could serve whoever walked up. Marriage and family, which that's how I got my marriage and family. Marriage and family interest to the severe and persistent mental illness. As things have changed, then we get into more priority populations in terms of how state funding looks at it. And so then you get this, you know, walking well that is doesn't have as many opportunities. You know, you can go to your church if it has a counseling service, or you can go to the counseling center, or you can go to places like that, but you can't go to places of where, well, I just have some marital issues, or I just want to look at it in this way, just some short-time therapy stuff. You don't have a lot of that. So then when you get into the more severe pieces of, and you look at peer, we have a tendency to think that mental illness is illegal, and it's not. It's not illegal to be mentally ill. It's not illegal to have cancer. It's not illegal to have a heart condition. Now, where the legal issue comes in is if you're dangerous to self or others. But just having the illness is not illegal. Just saying, I don't want to be treated is not illegal. So sometimes when we look at the stigma, when we look at that aspect of it, we jump over in terms of a legal issue versus a health issue. Terrell State Hospital used to be called an insane hospital. Insanity is not a medical term, that's a legal term. We now emptied out state hospitals. When I worked at its heyday, I think it was 2,300. It was in the 2000s, in the 70s. And I was there when it was deinstitutionalized. And, you know, you can look at that good and bad. It was a safe haven at one time for many people. It was an intentional community. And I don't know if many of you know what intentional communities are, but let's just say Texas A&M Commerce, in a way, is an intentional community. It offers food, health, many, many services that you won't find out in the real world. Taylor was talking earlier today about prisons and jails. In a prison, you can get a lot of services that you wouldn't find that was in the community. So at Terrell at those times and at state hospitals across the country, you offered all of those services. And dental was probably the biggest one that I saw in the 70s is that if you came to the hospital, you immediately went to have a dental exam because many people had dental issues for years and it was causing them lots of stress and pain. And you'd pull some teeth and all of a sudden magically they would go back to their communities and well. You know, we have to look at that. Peer services is probably the biggest in terms of getting people to identify with one another, but you have to have a place for peers to go. Here in this community in Greenville, we got a grant from the North Texas Behavioral Health Authority and have a coffee shop, we call it Picnic, where people can go. When we got everyone out of the hospitals, you know, Cooper was a town that we probably put 150, 60 people in that came from the state hospital. And you say Cooper, Texas? That's actually where East Texas got its start, if y'all know the history of Mayo College. And we paid more money, but we tried to create intentional communities around people to get them out. Now, most of those people have died now. So mental illness, people who were in those institutions, people who have mental illness now, we often say they have a shorter lifespan. But over my career, their lifespan has increased tremendously because we have offered more services in a lot of different ways. But peers is probably the big way how to destigmatize. How many of y'all belong to NAMI, National Alliance of Mental Illness? Good organization, Mental Health America, good organization. If you want to look at how peers, now I've learned a lot today about Rotary, and I think it's probably going to take its course up there with NAMI and Mental Health America. Be involved in those organizations. That's how you really do look at how do you destigmatize.
Okay, thank you. I'm gonna shift ahead to another question that I'm very passionate about. This is my own want to know more about it. But how can we attract and retain mental health professionals in rural communities? Because it seems like that's a larger problem. It's the idea of we train them, we get them ready and prepared, but we never seem to have enough. There's never enough to fill that void. So maybe talk a little bit about how can we maintain and retain and attract?
So I'll talk about attraction first. We probably don't have as much issue about attraction. You know, I can remember talking with a unit chief nurse many years ago, and she said, whoever comes to the hospital and wants to apply here, most of them are good people. They're wholesome. They want to give. And what our role is to remove all the bureaucracy so they keep giving here. Because if we throw up a lot of bureaucracy, then they're going to go give to the Girl Scouts or their church or the Rotary or the Lions. And we need to be real. We need to let them give all of those services here. But you look at how do we retain. So there was, 40 students that, raise your hands. All right, I want to be curious how many of you are here in 5 years in the profession, 10 years in the profession. Probably not very many in 15 years, not a lot in 10. It's going to be money. It's going to be benefits. It's going to be see how you're perceived in your community by your peers. It's going to be social media. It's going to be all those things that well, it's easier if I go over here and I don't have all that paperwork to do and I don't have all those rules and regulations to do. And the bureaucracy will get in your way. It'll be money and bureaucracy. And your friends will say, why don't you come over here? I just got a big promotion. You know, we're not one to give a lot of raises. And when we do, they don't even match, you know, what the cost of living is. So it's money. There's a lot to do with it. The professionalism. I think you'll stay more engaged if you stay involved in your organizations, your professional organizations, and in giving in various different ways. I think that's probably the best way we have to retain now, because I don't think we're all going to get a big salary increase. But I think we have to keep working at that. We have to keep telling our elected officials that and prioritizing it and
Thank you.
I'm going to put my provost hat back on and tell you about all the great places we have at the university where you can send your friends, your family, your colleagues, your coworkers, send them to the university. We have all kinds of mental health opportunities, whether it's counseling or social work, human and health performances. Help them to get educated, because we know that if people are educated in their home, their home area, and we are the University for Northeast Texas, they're more likely to stay here. But also what we have to do is look at how do we help train paraprofessionals. And I want to just say one quick thing about money. I want everybody to have a good salary. Don't get me wrong. I believe in that, and I want people to be paid. But I also know that the research says is it can't be, and it isn't just about money. That people, and I won't ask you to raise your hands, but I expect many of you here today could make more money in a different area doing something differently than you do now. But you're in your job, and you came here today because it's not just about the income, it's just not about the money. And we know this. So what is it about you, what is it about being here today, about this community that keeps you here? And how do we continue to grow that and share that and create a community where everybody really does want to stay, or better yet, people want to come join us, and we continue to have that kind of a community that people want to be a part of, because there's something more than just the paycheck.
It's hard to expand on that. I think that they've covered so many of the barriers to us keeping our trained up mental health providers here in our communities. A lot of people are very attracted by going into the larger cities, and it's easier perhaps, and perhaps there's more pay there. So then that leaves the question that Adam brings up is, how do we keep people here? How do we reignite that passion for this community, for our community? I'm trying to think about some of my colleagues and the things that they maybe express dissatisfaction with, and what kind of leads them to go out into other areas. I know that training is a big one. I don't know if this exists in all of your agencies, but I know that for our agency, a lot of my colleagues would complain that we don't get enough training and enough poured into us to equip us to be able to do a good job. And that's what we come to work for. So essentially it's kind of, in some ways it can handicap us. Although with that said, it's kind of our responsibility too to seek out those opportunities for training and enrichment in our careers. So, but that's a big one. And then I like what you said about paraprofessionals. How can we pour into people it's difficult to go and get a degree and get a master's degree and get a license and to go through all of that work. And I know that it's necessary and we need it so that we can be equipped to be able to provide the kind of care that we need to. But also other people can be trained too. So like at Glen Oaks, we have the MHTs. How are we training them so that they can serve our acute psych population? And they don't have to go and get their degrees and things like that, but providing adequate training and support to those people too, I think is important, maybe an area where we're lacking.
I can think of two things at least. One of them is that often you have college debt. When you graduate, maybe there's some sort of tuition reimbursement to go work for a facility for a while. I know lots of hospitals will do that. and help you. And then hopefully, too, you want to be able to do your internship someplace close to home where you want to live. I know I had a friend who graduated at A&M Commerce with his master's in social work, and he had to drive over to Arlington to get his clinical internships and that sort of thing. So maybe we could all work together to find places here closer in the rural areas where people could do their internships and then be able to stay here because they've developed those relationships. I think that would be an important thing to do, or a possibility.
I'm sorry. I'm just going to ask all of the VPs from A&M Commerce, all of the deans, other administrators, and all the faculty. Would you hold your hands up for me, please, and let people see where the A&M Commerce current leadership, students, faculty, administrators are? Please note who's in this room and that we want to help you. We want to help you to provide that professional development training. Again, collaborating with you when it makes sense, leveraging our resources, and we take that responsibility very seriously. So I hope as you're talking about professional development needs, you think of the people in this room that raised their hand, and thank you all, colleagues, I appreciate that. And also, Shirley, how do we get those kind of connections? I will tell you, university, by definition, we're educators, and so we're educating students, but they need that internship. They need those real life experiences, and that's another way that we can connect and go across the town to gown relationship. So thank you.
Let me give a plug as well. So Pat Denson, raise your hand. So Pat is in our HR department. She's right over here at this first table. We do loan forgiveness. Go see her in terms of employment. My hat's also off to Glen Oaks. We will have an event here free in this room in May the 27th for LCDs, for licensed chemical dependency counselors, LPCs, social workers. I think it's going to be on fentanyl. It's free. We'll try to promote you to come work for us, but it's a free CEUs. And Glen Oaks has worked real well with us over the years.
And we always want our students to have jobs, so please let us know, because that's at the end of the day, we transform students' lives so they can go out and have the jobs and make a difference in all of your agencies.
Well, Shirley took my tuition reimbursement one, so we spent a lot of time together, so we think alike. So, but I would just say, you know, it may not be in line with our so-called modern society, but I think it's a calling to do, you know, what you're going to do, these students here. And I would just tell you, I was in education for 20 years as a teacher and counselor. If you're going in it for the money, get out and change majors. You ain't going to get it. That's reality. And I always told my fellow teachers that too. It always annoyed me when a teacher complained about the salary. Okay, you knew that when you got in the profession. Shut up and do your job. I'd say the same to you students. Don't whine about it. I think it's a calling. I really do. That may sound whatever, but that's my belief. You don't have to have that, but it doesn't have to be a spiritual calling. Obviously, from my background, that's where I take it, but you don't have to be a religious person to feel it's a calling. It can be a secular calling for you, and it can be just as strong. But that probably doesn't exactly answer Adam's question, but I think it's a good piece of advice for the students here. And for universities, foster that feeling. This provost down here, she can help foster that feeling among the professors in this room. Talk to them about that. Talk to them about what you're doing for society. You're doing something for society that most other professions don't do. In a lot of ways, you are a first responder, just in a different setting. So that's my take on that.
Thank you. And before you hand the mic to someone else, just sort of a play off of that, talking about, you were mentioning about schools earlier. Suicide prevention is, I know it's a big area. If you do anything with mental health, and Shirley can attest to this, is suicide prevention. It is one of the most important things, important aspects of the work that we do. And we know it doesn't happen as we get older. So our school systems, K through 12, so what do we need in our K through 12 school systems, that particular age group, to help bolster the efforts in suicide prevention? And I'll let you start with that one, Tony.
Well, I've taught every level from first grade through community college. And I've been out of the profession for a while, so I'm reticent of saying what it's like now, but when I was in, it really wasn't discussed. Of course you have counselors, our counselors are trained, but I think of all the professional development I did as a teacher, and I do know teachers in the field currently, it's not discussed. They're not trained on mental health. They don't go to assist training. They don't do a lot of things that would be real professional development instead of a lot of the junk that we're forced to do. So I think it starts with having good professional development for teachers who can then discuss with parents, who can then discuss jointly with children. That'd be my suggestion.
I actually have a list.
I figured.
So one of the things is, especially we're talking about professional development for teachers, there's actually state funding for staff members of schools to have mental health first aid, like through the North Texas Behavioral Health Authority and other health authorities. So there is funding to be able to offer mental health first aid, not just for the teachers, but for your transportation folks, your cafeteria folks. Sometimes they're going to see things that the teachers or the counselors may not see. Also, there is availability of lots of free programs. NAMI has a great Ending the Silence program that they will do for free in your schools, either over Zoom or in person. The Grant Halliburton Foundation also has programs for all ages, and especially Hope Squad peer programs for high school kids. Then the folks from the North Texas Behavioral Health Authority with Mental Health First Aid also has a peer program for high school kids. You were mentioning resilience training earlier. Actually, the UT Dallas Center for Brain Health has a middle school program that is funded by the state, and they offer stipends for the teachers, by the way, if you use this. And it teaches resilience, not what to think, but how to think, and teaches you different techniques, and that's available for middle schools across Texas, in case you're interested in that. Insofar as the elementary schools, for example, at Little Elm, they actually every Monday morning have a little slide deck they pull up. They do some four-step breathing. They do meditation, and they have a little screen that comes up and says, if you're feeling down or anything like that this week, this is where you go. And so they do that every week. And sometimes they do some things every day. So they do the breathing exercises every day, and they talk about that. We have at our table a program that was created by the state of Connecticut called Gizmo's Possum Guide to Mental Health, and it is free. Every household can order the little book about a little rescue dog talking about his friends and how he feels and talking about trusted adults. There are things like that that are available actually for free that we can use. Mental Health America offers free mental health screenings and will actually come in and work with your counselors to then follow up with students. So there's a number of different things like that that are available. And fun stuff like PTA meetings, do brain games. We've done that before at PTA meetings. They love brain games, and a lot of times the kids are better than us grown-ups, okay? Because, we're kind of set in our ways. So they can do lots of different fun things, and it's really working out their brains.
I love that. I don't think that most of us know this. I need your number for sure. Yeah, you have a lot of resources. So, yeah, I completely agree. I think that professional development opportunities, we need to be more mental health focused for our teachers, not just the mental health professional in the school, but certainly the teachers. Also, what comes to mind too is like peer support, or like the older kids in the classrooms, or the older kids at high school could maybe help to model things or teach and provide support to the younger students. I'm not in the school, so I don't have a whole lot of knowledge about how that stuff is currently structured. And again, I love what you said about, I guess there are schools where they are providing that kind of very very foundational, those very foundational skills for how to navigate life in general for our young people. So, yeah, that's all that. Yeah, I forgot Adam's question now.
You answered it. You answered it.
Just in schools
Yes.
and okay.
Uh-huh.
Sure. So I have a Texas secondary teaching certificate as well. So I'll go back to the whining piece. If you want salaries increased, you have to whine through your professional organizations and through your elected officials. I don't care. I mean, I've hired people for 40 years, and I lose people every day. We have a crisis in the mental health and education field, and it's around salaries. You can't make a living on the salaries that we pay entry-level people in our fields. And it is up to us to raise those salaries and increase that awareness level. I'll just say that right off the bat. In terms of the other piece, so how many of y'all in here are in education in terms of you're going to be a teacher or elementary or secondary education? So you probably have a little bit in terms of lesson plans and stuff. Those of you social workers and LPCs and psychologists, how many of you are being trained in electronic health records? Raise your hand. That is probably the key thing if you're working with kids or adults in our field that I didn't get when I was in school and I don't see in graduates. Is when you enter the field, you don't know how to document. You don't know how to bill insurance. You don't know how to bill the state. And it's incredibly frustrating for you. And so when I say that bureaucracy, that is the one thing that we spend so much time on and trying to get people how to learn is how to document and how not to falsely bill or falsely get themselves in trouble. And then we were shaking our finger at you, and you go, "I'll forget it. I'll go do this. I don't have to put up with that." I would say in education, in terms of working with kids as well as adults, it's more in learning your electronic health records, learning what artificial intelligence is in terms of apps, in terms of what, I have a 5-year-old grandson that, he's strapped to this computer. It's not a phone. He doesn't call anybody, but it is this powerful computer that he already knows more apps than I think I did when I was, however old I was. But, it's apps. There's lots of things in the kids' world and parents' worlds now in relation to applications on phones.
Yeah, and I'll take this. I'll give this next question to Dr. Vakahasi. So this is a big ask. So if you could change one thing about the state of rural mental health and in mental health in general, what would that be? What would be the one big thing?
Yeah, I wish I had the answer, the one right and only answer, but the bottom line is we all know there isn't one, right? There's a lot of things that need to be changed, and everyone here in this room is an agent of change, and I'm so excited about that and the work we're going to be doing at the individual tables. One of the things I think about a lot when it comes to mental health in general, also mental health in campuses, but I think it's true across, is where we invest the money. And it's a V, if you think about it, or excuse me, it's an upside down V, where we do very little in the proactive and the prevention as far as investing, but then it goes down, right? And then at the treatment level, that's where we often come. Now, I will say not enough, by the way. We need more resources. We need more opportunities for people to get these really needed interventions. So we need to fund those. But I wonder if we thought about turning that V up, or turning the V up, right? So that we put a lot more of the funding into the being proactive to being preventative, and what would that look like? And I appreciated our keynote speaker, because I think he was making that point in a very different way and probably much more elegant than I just did. But that we put a lot of intervention and opportunities for treatment and people to talk to after people are incarcerated. Imagine if somehow we flipped that and we were proactive and we helped people before they were in that crisis mode, that we helped them to have the coping skills, or at least the knowledge and the access to what they needed to be preventative. So for me, it would be flipping the focus on not forgetting about intervention. I want to be clear that I believe in that, and we need to provide that kind of treatment for our rural community members. But are we needing to also, and I believe truly, looking at how can we be proactive and preventative?
So in Texas right now, in the legislature, there's All Texas Access. This started with 2 legislative sessions ago, and it's aimed at communities less than 250,000, to counties that are less than 250,000. So we're the mental health authority of, let's say, Paris, Mount Pleasant, Mount Vernon, Sulphur Springs, Cooper. All those counties combined are less than 250,000. So when the state looks at its funding for urban, rural, and frontier levels. So we're in that rural area. You take out in far west Texas, of where you have, far more square mileage than you have population. Those are frontier areas. It costs more money to do services in rural and frontier than it does urban. You have more churches, more organizations, more civic organizations. You have more opportunities as you get more population. We don't have as much in rural Texas now as what we did 20 years ago, and not really, but we used to have a lot of bus therapy. So you go to the Ministerial Alliance and you go, this person showed up in our community and we don't know what to do, so we do the good thing. We feed them and give them a bus ticket to Dallas, and then they become homeless. So there were a lot of communities that did a lot of bus therapy. We have a lot of communities that still say they have no homelessness in them. Maybe they're right, maybe they're not, maybe they're just hidden, I don't know. But we have a lot of issues in terms of rural areas. If you do home visits, if you do services where you want to do them in the real environment, in vivo, at the place where they live and work, it costs a lot more to do that in a rural area than it does in an urban area. We've gotten a lot more transit systems now than we have had in the past. But it's very difficult for people that have a medical condition or a mental illness condition to navigate it. It's very hard to navigate health care if you don't know much about it. It's very hard to navigate it if you know a lot about it, if you have an illness. And so rural is, you got to tell people it costs a lot more to get rural health than it does urban health.
Yeah, and I'll just add, of interest, the prevalence of mental health is the same in urban as it is in rural, and that's why some of the challenges that we faced are just so drastically more.
So the one thing that I would love to see change, I'm sure that we all would love to see change about rural mental health. One thing that I think we're all encountering is wait lists for people. I don't know what all the reasons are. I'm sure that we've touched on a lot of the reasons for this, but especially since COVID, and one of the things about increased awareness and acceptance of mental health problems is that so many people have flooded the field and they're seeking out services, but there aren't enough providers. So then that circles back to Adam's question, of course, about training up more providers and then keeping them here and retaining them. But the wait the waiting list is a huge problem. People are waiting and they get frustrated, and then or they think like, oh, I'm feeling better now, I'm not gonna go to this appointment, and they cancel. So having more immediate access and home-based stuff, I mean, in like a fantasy world, then we'd have, readily available services to provide to people in their homes and really remove a lot of those barriers to treatment. But yeah, I have professional contacts as well as personal friends, family who contact me, and they're like, I cannot get a therapist for 8 weeks, 12 weeks. And so I guess maybe figuring out how to get past that and get more services that can be more readily provided to people. I think that's a big thing. Another thing too is providing help and support for people after they transition out of acute care with especially prescriptions. So many of our people go off of their prescriptions, and I know that there are some nursing like at-home nursing agencies that provide in-home support, but I'm not real knowledgeable about how that works or how to link our people to those resources. But so many people come back in acute care because they went off their medications. We all know that that's happening all the time, everywhere. So how can we better provide follow-up care for our people after they leave inpatient to prevent rehospitalization? That's another big one.
I think it's really important for us to utilize the dollars that are going to be available through the infrastructure bill to improve internet access in the rural areas. Because I know that even if I go to my husband's aunt and uncle's house, if I don't turn down the right road with my phone at a certain time, I lose signal. It's like, whoop, which road am I supposed to turn down? There's no internet access out there. Now, some people don't feel comfortable doing telehealth. That's true, but it is something that could be available, even with peer support groups. NAMI now has online peer support groups, so you can join in English and Spanish, by the way. So those are available that you can do online. I lead a support group for survivors of suicide loss over Zoom, so you don't have to drive anywhere, so that you have access to that. But you need internet access to do it, and we know that it's iffy in lots of places out in the rural areas, and you're lucky if you get old modem speed, if you get something, but that's something that I think is really a need that we could maybe push for to get those dollars and have those available. And of course, community engagement is really important, that we talk about things as a community and support each other as a community.
Well, I agree with what everybody said, so I won't repeat it. You already heard it once. That's enough. I would just add something that we each can, I mean, this stuff it's through policymakers, it's through things like that, but what can we do as we walk out the door later today, like immediately? And that is, we can help begin the process of destigmatization. And I will still go, at the risk of beating a dead horse or whatever, I will still go back to that because I think it's just the foundation for everything else we've been talking about here. And we can do that, like individually. We don't need a politician. We don't need a provost. We don't need anybody. Like we can do that individually, just in our daily interactions. So that's what I would recommend that we do. Treat people, it's like if we find out somebody has cancer, we start bringing them casseroles. What do you do if you find out somebody has a severe mental illness? Most people, they back off. Not because they're necessarily discriminatory, but people are scared of what they don't understand. And that's something we can do. One reason I do a lot of community events is because I want you to see I'm a severely mentally ill person, but I'm not that different from you, right? I have different struggles, but we participate in society just like you do. And so that's what hopefully, if you don't remember anything else or care about anything else I said, hopefully you'll practice that treating people how you want to be treated. Whether it's a mentally ill person or a person with a physical, whatever, just, it's kind of like the golden rule. Just try to treat people how you want to be treated. We'd have a lot better society.
And along with those lines, our language makes a difference. How we talk about mental health and about suicide. You say died by suicide. I will tell you, as somebody who has lost their only child to suicide, it hurts when people say commit suicide. It's not a crime. He didn't commit a crime. So, but there's that negative connotation. And so for us to help other people get used to saying died by suicide instead of commit suicide, we just have to be an example. And you're going to mess up. You know, you're going to say it sometimes if you're used to it, because it takes time to get used to changing that language. We don't say, you know, complete suicide. I know that's like a clinical term, but complete's like a positive connotation, but it's not positive that they died by suicide. And people are not their mental illness. They live with a mental condition or mental illness. They are not their mental illness. So our language makes a difference. And if we can do that, if we can go out and do that in our communities and get people used to saying that, we don't commit cancer, you know, so we die by suicide instead of commit suicide. That's a big step. That's the first big step we can do.
Yeah, and with that, I think we're going to wind the panel down to a close. We're right at time. I really want to thank our panelists today. That was a really good in-depth discussion. And as we move into the afternoon, when we do our roundtable discussions, I think I forgot to say this, but think of what we kind of talked about here on stage and the questions that we were asking, and that should help guide the discussion at your table. This is just sort of the beginning part of that, so we want the real work to happen at the tables, and so we can kind of come back to these very important issues. So let's give them a round of applause.